Hi, and good morning. Thank you for joining us for our Facebook Live Q&A session. My name is Jamie, and I'm here with head and neck surgeon Dr. Eric Moore, as well as head and neck surgeon Dr. Daniel Price. Both physicians reside here at the Mayo Clinic in Rochester, Minnesota. Today we're talking about parotid cancer, the background of parotid tumors, surgery for parotid tumors, recovery, and additional care after parotid surgery. Throughout the broadcast, we will be taking your questions, so please make sure to post those in the comment section below. So Dr. Moore, if you wouldn't mind starting us off by talking about the first steps that someone would take when they notice a lump in their parotid gland.
Well, thanks, Jamie, and I'm excited for this session, the questions. It's a great question because although sometimes patients can show up with a parotid tumor because it was found incidentally on some type of scan that they had, most patients notice themselves that they have a parotid tumor. The parotid gland sits so close to the skin and in a prominent area of the body, the face, so most patients feel the tumor themselves and then decide, what should I do next? And I'd say the first thing that they should do is get evaluated by someone who has some experience with parotid tumors, because often parotid tumors are mistaken for something that's right underneath the skin or right on the skin or potentially even a skin tumor and get inadvertently biopsied before the whole workup is done. And sometimes parotid tumors are mistaken for lymph nodes and then again get biopsied or the workup kicks off maybe in a different order than you would do for a parotid tumor. So the first step is to seek out a professional, an ENT surgeon who deals with parotid tumors and get an evaluation. Now, the good news is that most of the time when you have a parotid tumor, it's not a catastrophe. It's not a disaster. Most of the time, it's not a malignant cancerous tumor. Most parotid tumors are benign. So to ease people's minds, they have a parotid tumor, they go in and get evaluated. Most of the time, they're going to find out that they have a benign tumor that can be treated well and their life can go on.
Perfect. So Dr. Price, once a patient has been evaluated by their physician, what happens after? Can you talk about imaging and the process of evaluation?
Sure, that's a great question, Jamie. Good morning. So after a patient has seen a surgeon about their parotid tumor, they may order a variety of tests. There are a number of different types of x-rays that we might do to evaluate a tumor. And the most common thing would be a CT scan, but we might do an MRI. We might do a PET scan if we're concerned about a malignancy, and oftentimes we'll proceed with a biopsy. The most common way we biopsy these tumors is with what is called a needle biopsy or an FNA.
Okay. And for diagnosis of a parotid tumor, does a patient have to have a biopsy? And if so, once the area is biopsied, can that disturb the tumor? Can it spread?
Yeah, that's a great question too. And I would say the decision to perform a biopsy is really individual based on how the patient's presenting. What are their symptoms? What are the other factors surrounding the tumor that lead to an idea that it may be benign or malignant? And in many times, this is very practice dependent. So it's essential at some point in the workup of a parotid tumor to know what type of tumor it is, what type of benign tumor or malignant tumor it is, or possibly even metastatic tumor that it is. So at some point it's going to be necessary to invoke the help of a pathologist and get that information. But the question of whether to perform a biopsy right away is really an individual one, and there's a lot of nuances to the type of biopsy that you can do and the type of information that you can get out of it. First of all, I completely agree with Dr. Price that a needle biopsy is the way to go if a biopsy is going to be done. A needle biopsy is what we call minimally invasive or relatively atraumatic as compared to an open biopsy where an incision is made and a whole piece of the tumor is taken out. One of the hallmarks of removal of parotid tumors is that you want to try to keep the tumor intact as much as possible, and particularly keep the capsule of the tumor intact. And so a needle biopsy doesn't violate that capsule or violate those rules and really lends itself to some effects of surgery that are beneficial. The question of whether the needle biopsy spreads the tumor is a very hot topic. And so to get a biopsy, you have to take cells out of the tumor. So you have to create at least a micro breach in that capsule to get those cells. And when you perform a needle biopsy correctly, the micro breach has never been found to lead to spread of that tumor in the tract. So we feel like needle biopsy is a very safe thing to do, and most of the time can provide you some very beneficial information. And so then the question becomes, well, why wouldn't you perform a needle biopsy every time? Or also, what type of information are you going to get out of that biopsy? The one problem with needle biopsy is it can be very challenging for the pathologist to interpret. The analogy that I use with patients is a piece of the tumor is like looking at a major part of a picture, and the pathologist can usually tell you, well, that's a picture of X. But a needle biopsy just gives you minute amounts, just specks of color maybe from that picture. And a great pathologist who's very experienced in needle biopsy can, most of the time, greater than 90% of the time, get the correct diagnosis. But rarely, if ever, can the pathologist make the diagnosis with 100% accuracy. And so this is where some problems come into play. A patient gets a biopsy, they're told they have a benign tumor, and they sit rest assured and don't do anything about it, and possibly the needle biopsy is incorrect. It's not a benign tumor, and even if it is a benign tumor, which I'm sure we'll go into in the questions, something still needs to be done.
Okay. So we have a question from our audience. Our first question is, how do you know when the lump is not a cyst, swollen lymph node, or something else?
Great.
That's a great question. So I think the first part of that starts with seeing someone who's experienced, as Dr. Moore mentioned earlier. It's not uncommon for lymph nodes to swell when a person has a cold, for example, in their parotid gland. But that should be related with a cold. So if you have a cold, it lasts for a couple of weeks, and you may have lymph nodes that swell, and your cold goes away, and that lymph node swelling should go away as well. If you feel a lump that lasts longer than that, though it sticks around for weeks after your cold is resolved, you should start to think that maybe this isn't just a swollen lymph node. So that's something that your doctor can help tease out by asking questions and doing an exam. And then that's also where imaging may play a role. So that's maybe where we'll think about getting a CT scan or an ultrasound to further evaluate that lump.
Perfect. Thank you. So we have one more question, if that's okay. The next question from our audience was, I noticed the bump by my ear and jaw around 2001. I finally had it diagnosed and biopsied with a fine needle aspiration in 2007. I've never felt any pain at all. Over the past 10 years, it's grown minimally, and I've had it scanned every other year. I've left it alone. With this benign tumor, what is the urgency of removal? I'm 50 years old and generally healthy otherwise.
So I'm really glad that this question came in, because I think this is one of the key points in parotid gland management. Benign does not mean do nothing about it. Benign does not equal it's okay to watch or even ignore this tumor. It's one of the pitfalls of parotid tumor management is that even the benign tumors can cause some problems. And so in the least sort of noxious of cases, the benign tumors can grow and become larger. And it's very fortunate that this person's had this for so long and it really hasn't done that. But stability itself isn't totally reassuring, because not all the benign tumors grow at what we call a regular or linear rate. Sometimes they can sit sort of quiescent for quite some time and then grow for a period of time and then be stable again. And that can be all consistent with the behavior of a benign tumor, but you never know when it's going to do that. But I guess more concerning is that some of the benign tumors can transform. And we always say it's a low percentage, something around 10% of the benign tumors will eventually turn into something more aggressive, such as a malignant tumor. But there aren't very many factors that you can lean on that tell you when or if that's going to happen. And so there are cases when we tell people, you probably shouldn't do anything about this. Our confidence is high that this is a benign tumor and you can probably watch this, but most of those cases are not in 50-year-old people who are in good health, because we're expecting that their good health and their young age is going to lead to longevity, which is going to allow that parotid tumor to become a problem at some point, and we would much rather treat it when it's small and when it's easily manageable, than when it has started to grow and become quite large, or even worse, when it's become a malignant tumor. So our advice to people, it's great that it's benign. It was a good idea to do the biopsy and get that information, but it still should be managed, and you're really rolling the dice or taking a chance watching that tumor for such a long period of time.
Great. Well, thank you. So we'll go ahead and move on to the surgery for parotid tumors portion of our talk. Dr. Price, I'll direct this question to you. If you could answer and talk about the different types of parotid surgery.
Sure, that's a great question, Jamie. There are a dizzying number of terms for the different types of parotid tumors. I'll first say that there are a number of critical steps during a parotid surgery, but there are two things that are essential. One, Dr. Moore's already mentioned, and that is our principle that we don't want to violate the tumor. So one of the most important things we need to do in determining what surgery to do is that we get the entire tumor out without violating it. The other thing is that the nerve that moves the face, called the facial nerve, runs through the parotid gland, and we want to keep that nerve working as best we can. The most common procedure we do is what's called a superficial parotidectomy. Approximately half of the gland is over the nerve that moves the face, and fortunately about 2/3 of the tumors will be in that portion of the gland, and we typically will remove all of that gland over the nerve. There are some times for small benign tumors that will do less than that. We'll try to preserve some of the gland, to try to preserve some of the function of that gland, and try to minimize the impact of the operation. Those things are called partial parotidectomies, or sometimes something called an extracapsular dissection, but those are rarely done and need to be done in experienced hands. The most aggressive operation we do is what's called a total parotidectomy, where we remove the entire parotid gland, usually trying to keep the nerve that moves the face intact. Only rarely, if there's a cancer that involves that nerve, do we actually take the nerve out.
Okay. Is it possible to just go in and remove just the tumor?
It is possible to do that, but we almost never do that. These tumors often look well defined, but can be difficult to see where they start and stop. When we do something like that, we often leave tumor behind, which will lead to not only one recurrence, but often several dozen recurrences of the tumor, which become almost impossible to treat. And we turn what's a benign tumor into something that's very similar to cancer, even if it doesn't become cancerous. So we never recommend that. In only the smallest number of cases will we do something like that.
Okay, thank you.
Jamie, I wanted to dovetail on just a couple of things that Dr. Price mentioned there, because there's some really essential points that are not obvious to everybody. There are many different types of procedures that encompass parotidectomy or management of a parotid tumor, and you're really trying to individualize the extent of that operation to what you're dealing with. You're trying to do just enough treatment so that you adequately manage the tumor and that it doesn't come back. That's the name of the game. But you're also trying to minimize the effect of that treatment on the person. You're trying to minimize the surgical impact, the defect, that, like we call it, the facial nerve paralysis and weakness that can result. And so you're making hundreds and hundreds of decisions during that procedure to balance those two things. And this is really where the team concept comes into play. Because if you say, well, I'm really interested in trying to do a very minimalistic operation here and just take out this tumor, and then you find out several days later from the pathologist possibly that it wasn't a benign tumor, that it was a malignant tumor. Well, what do you do now? Now, was your margin of resection adequate? Should you go back and do more surgery? This comes up all the time, and this is why it's so important, we think, to have information regarding pathology at the time of the surgery so that you can make informed decisions and do just enough at the time of the original operation. The time to treat the tumor, the best time to treat it is right then at the original operation, and subsequent revision procedures become more and more complicated.
Okay. So let's talk about what makes a parotid surgery such a delicate procedure.
Yeah, that's a great question, and the obvious answer is because the facial nerve sits right smack in the middle of the parotid gland, and this is what worries people so much. a parotid tumor would be completely simple to deal with, and there wouldn't be so many people that have reservations about getting it treated if it wasn't for the fact that that facial nerve is in play. What is the facial nerve? Well, this is a great time. We have a graphic, I think, that we could refer to and bring up to sort of emphasize this. But the facial nerve is a nerve about the size of a spaghetti noodle and about the same consistency that comes out of a small hole in the skull just below the ear, and it travels for a short distance and then it dives into the parotid gland. It runs through the parotid gland, and at the time that it's in the midst of the parotid gland, it branches into different branches that supply the muscles of the face with movement. And those different branches that it branches into are very tiny. They're about the size of a hair as they exit the parotid gland. And so the whole sort of nuanced surgery of parotid gland is how to safely manage that facial nerve and work around it and see it and protect it, but not to injure it. How does it become injured? Well, it can become injured by stretching it. It can obviously become injured by cutting into it. And so management of parotid gland tumors consists of completely removing the tumor with its capsule intact and all the little pinches that the tumor might have, and still safely protect that facial nerve.
Okay, thank you. So what do you suggest patients look for in a skilled and experienced surgeon?
I think that there's no substitute for experience. And so, like any manual skill, surgery gets better the more times that you do it, and then continual practice maintains that skill. And so the casual operator, the parotid gland is not a place for that because of the maintenance of skill and the sheer fact that you have to have numbers and experience to perfect that skill. But even more importantly, I think, than the technical aspect is all the decision making. Sure. And so having a team around you that helps you with that decision making, having a very experienced pathologist that can give you reliable information at the time of that surgery, having great anesthesia colleagues who can manage the blood pressure during the surgery so that the bleeding is not obscuring your view of the facial nerve. Having good technical skill in not only management of the tumor, but management of the tissues around it, and perfecting the closure and minimizing the scar. All those things are important. So, you know, a lot of great surgeons that are trained can take out parotid gland surgeries, can take out parotid gland tumors, but it's really not the place for people who don't have good experience.
It's helpful information for our viewers. Dr. Price, would you touch on some of the side effects and complications of a parotid surgery?
Sure. That's a great question. We've talked a little bit about the nerve that moves the face, that runs through the gland there, the facial nerve, which is certainly the thing we worry about the most. But there are a lot of things going on in the parotid gland and around the parotid gland that we have to think about during the parotid operation. So first of all, the parotid gland's a spit-producing gland. It produces saliva when we eat. And one of the most common side effects of having all or a portion of your parotid gland removed is that people get something called Fry's syndrome, or gustatory sweating. That doesn't happen right after the operation. That usually happens about a year after the operation, but it happens to most patients who have that surgery. What that is when a patient eats something, particularly something sour, instead of producing saliva, they'll have mild sweating from their cheek, right where the parotid gland was. It's usually very mild. Usually the patient doesn't notice. If we ask them about it, or if we put a lemon drop in their mouth in the office, they might have some mild moisture that we can detect. If that happens, there are things that we can do about it. The simplest things is to put antiperspirant on the face when the patient goes to bed, wash it off in the morning, and that usually takes care of mild things. For more significant episodes of Fry's syndrome or gustatory sweating, we can inject Botox in the office, and that's very effective. There's another nerve that we didn't talk about that gives you sensation on your ear and the cheek in front of your ear. We try to save that nerve if possible. It's called the great auricular nerve. But it's very common that we have to cut some or all of the branches of that nerve, which will lead to an area of numbness. It starts out fairly large over the cheek, and over time it will shrink down, and usually patients will have a small area of their earlobe that will be numb. I think when we see patients back a year after surgery, that's probably the most common thing that they talk to us about. It's very minor, but they notice it. People who wear earrings will notice that. When they put their earrings in, they can't feel it. People who shave their face will notice when they run the razor over their face, they don't feel it.
Okay.
The gland is thick. It's about as thick as the thumb muscle here. And when we take that out, people's jaw becomes a little bit more prominent. Usually that's a minor cosmetic upgrade for people. When we take a lot of the gland out, or in very thin people, that can become very prominent. And so occasionally we'll put a little filler in there, usually fat from the belly, to try to disguise that. Of course, the nerve that moves the face, in an experienced surgeon's hands, you shouldn't have any permanent weakness of the face, but people can have some mild weakness after the operation. Fortunately, that's temporary and usually goes away.
Okay.
And then the other most common side effect that people will experience after the operation is something called first bite syndrome. So during the first few bites of a meal, people may have tenderness when they chew. It tends to go away throughout the meal. It tends to only last for a few weeks after the operation, but in some patients it can be significant and last longer. And then you need to talk to your surgeon about how to treat that.
Sure. Thank you. So we're going to take a couple more questions from our audience.
Great.
Our first question is, why are we seeing so many recurrences after initial tumor is removed?
Yeah, that's a really interesting question. And I don't think recurrences are a new phenomena. We've seen recurrences throughout sort of my career in the history of parotid surgery. There have been recurrences, but the recurrences seem to be a little bit cyclical in their instance. And what this means is that there was a period of time when parotid recurrence was fairly high. It was quoted to be as high as 15 to 20%. And one of the things that altered that in a positive way was that people started to understand better the extent of parotid gland removal, how to manage the facial nerve. And during the era when superficial parotidectomy and removing not just the tumor but more of the gland became popular, the recurrence rate dropped significantly. Today, we have great imaging, we have great diagnostic tools, there's high interest in minimally invasive surgery, and people have swung back a little bit to more minimalistic parotidectomy. And very many good surgeons will take out just the tumor and a small cuff of parotid gland around it and do well with that. But I feel that the closer and closer we get to that tumor, the more judgment errors we might make in appreciation of where the actual extent of the tumor is. Many parotid tumors are not just a sphere or an oval, they're irregular in shape and can have sort of minute, what we call appendages off them. And the closer we get to that tumor, potentially, the more chance we have of leaving minute tumor behind that eventually will show up as a recurrent tumor. So personally, our philosophy is that we're not totally enthusiastic with just lumpectomy or just removal of the tumor for this reason, because I think ultimately that we are going to see more recurrences from that.
Okay, thank you. So we have one more question. What is the best way to tell if you have scar tissue or recurrence?
That's a really great question, and I'd say that judging from the person who asked that, as they know, probably it can be difficult. So the normal way to perform surveillance after a parotid tumor is with palpation, feeling the parotid bed, feeling the incision, feeling the area where the parotid tumor was. But scar tissue, potentially scar tissue that builds up after multimodal treatment also, not just surgery, but many people go on to have radiation also, and this can generate scar tissue too, can make it difficult to tell what's going on in that bed. And the first and foremost way to differentiate those two is with imaging. Okay. Some type of CT scan or MRI scan, particularly done in the serial fashion, with one scan followed by another scan several months later, can usually determine what's going on there.
Perfect, thank you. So we'll go ahead and move on to the recovery period after we've talked about surgery. Dr. Price, patients get concerned and ask about their face being swollen after going home from the hospital. Should this swelling be worrisome?
That's a great question. That's probably one of the most common phone calls we'll get after an operation is someone's gone home, they've been home for a few days, say my face is swollen, it's a lot more swollen than it was yesterday, what should I do? First of all, swelling is very common, and most commonly is just the natural healing process. People's swelling will fluctuate over their recovery period. Most of their swelling will be gone in about a month. but it will continue to resolve over the course of several months after their operation. It's also common day to day for some changes in how their swelling is. When patients go to sleep, they lie down, they're not moving around as much, and they'll get more swelling. So they'll wake up in the morning and they'll say, my cheek is more swollen this morning than it was when I went to bed last night. So most of that is common, fine, and not worrisome. Mm-hmm. The things that we worry about is someone who notes very rapid onset of swelling, when they have a lot of black and blue over their skin where the surgery was, that's new. And if they feel like there's fluid in there, so they squeeze it and it feels kind of like a water balloon, or firmer than that, like there's a golf ball underneath the tissue, then we worry that they either have what's called a seroma or a silicele, which is the residual parotid tissue, maybe leaking saliva out and collecting under the skin, mm-hmm. or if there's black and blue, we worry about what's called a hematoma, which is a collection of blood. Those things are important to get your doctor to see and treat, particularly a hematoma, because the skin is thin there, and that can cause problems with the healing, and we want to get that blood clot out.
Okay.
I think we should spend some time on this very valuable topic of recovery period mm-hmm. and healing. And one of the most valuable pieces of information and feedback that I've gotten from patients is the information that, Dr. Moore, you totally underestimated what was my recovery period. Mm-hmm. And I think that the difficulty is that recovery can mean very many different things. For some people, that means, well, when can I go back to exercise, or when can I go back to my regular lifestyle? For other people, it means when can I go back to work? For many people, I think it means, when am I going to feel normal again? When am I going to be back to myself? And this is quite variable depending on the extent of the treatment that they had. It can be quite variable for individuals, but I think as physicians we greatly underestimate the extent of that period because we don't always see the people at 3 months or 6 months out from a benign tumor operation to know what they're going through. So as sort of a general timeline, from a surgical standpoint, when is the incision well healed? When is it impervious to sort of being out in the open and bacteria and infections and things like that? I would say that's somewhere around 7 to 10 days. Most of the epithelialization or skin growth over the wound has started to occur, and that incision is fairly safe. It's uncommon to get something like an incisional infection from parotid surgery, but it's very uncommon to get it after a week. When am I no longer at risk for developing a hematoma or blood under the skin? That also is probably within about a week to 10 days time period where people can resume more activity, get their blood pressure up, and be out of the woods with that. Mm-hmm. But when are they going to chew normally? And when is their facial sensation going to feel normal? That may be as long as a year for some people, and quite honestly, for some people, they may never get back to total normality of how they felt before they had everything done there, because let's face it, even every minor incision is a wound mm-hmm. and leaves some lasting effect on people.
Okay. Dr. Price, do you want to talk a little bit about facial weakness post-operatively?
Sure. That's certainly the thing that people worry about the most. Patients and surgeons worry about that facial nerve quite a bit. Minor, for what we call superficial parotidectomy or removal of the gland over the nerve, it's common to have some minor weakness. The good news is most of that is going to go away. It does take time to recover. Nerves are very slow to recover. They don't like being manipulated, so when we have to move them around during an operation, they oftentimes will not conduct the electricity normally, even if the cord is still intact. So I'll back up a second and I'll say the number one way to deal with facial weakness is to see someone who knows how to treat your tumor and has experience operating in the gland so that you avoid any unnecessary injury to that nerve. If you have weakness of the nerve, one, hopefully your surgeon has talked to you about that and explained why you have weakness and what your expectation has been, and has prepared you properly for how to deal with it. We don't know of any particular ways to accelerate how the nerve recovers from weakness. We usually give patients some exercises to do, and those exercises typically involve using a mirror and trying to accentuate the movements that show off the weakness. So they've had surgery on the right side, their right eye doesn't close all the way, get a mirror, and they try to close those eyes as hard as they can over and over again. What that probably impacts the most is that not only does the nerve get weak, but over time the muscles get weak. Just like if you stop lifting weights, your muscles will get smaller. If you stop closing your eye muscles will get smaller, and you'll have some weakness there that takes some time to build up. So it will help with that building up. It's very important if people have weakness of their eye that they protect that eye. Our blink mechanism is incredibly important for getting particles out of our eye, for keeping our eye moist, and so we give patients eye drops to use throughout the day, and usually a thicker ointment to use at night. And for people who have very significant weakness of their eye, we may even do things such as tape the eye shut at night, or probably better is to place what's called a bubble over the eye that keeps it in a chamber that's moist so they don't get scratches and irritations while they sleep. And then when they're outside in the open air, they usually need to wear glasses to keep particles from going into their eye.
Sure.
For more significant permanent weakness, you may need procedures done to help manage with that. Usually those are focused around the eye, but we'll also do a number of procedures to focus on cosmesis and mouth function as well.
All right, thank you. Let's touch on chemotherapy and radiation. Does parotid cancer require treatment?
So the parotid gland has very many different cell types within it, and because of that, it can generate very many different types of parotid gland tumors. And as we mentioned before, the most common type of parotid gland tumor is a benign tumor, a pleomorphic adenoma, and benign tumors do not require radiation or chemotherapy for treatment in the vast majority of cases. Some multiply recurrent benign tumors, we will use radiation to try to decrease another recurrence, but mostly we're dealing with malignant cancerous tumors when we're talking about radiation therapy and chemotherapy. The type of malignant tumor is important in the decision of that question. So the high-grade, more aggressive malignant tumors are better managed with complete removal, followed by radiation therapy and sometimes radiation and chemotherapy. But there are parotid malignant tumors, cancers in the parotid gland, that don't require that much treatment. There are some low-grade tumors that are malignant tumors that we treat just with complete removal and don't use any other therapy besides that, aside from just surveillance and watching for recurrence. One of the most important factors in the determination of that question is, has it spread to the lymph nodes? So the parotid gland has lymph nodes within it, and one of the first things we ask our pathologists with malignant tumors is there any tumor in those lymph nodes in the parotid gland? That helps us make that determination.
Perfect, thank you. Dr. Price, would you mind talking a little bit about routine follow-up after surgery?
Yeah, that's a great question. I think it varies quite a bit based on what type of tumor a patient had. Again, the most common tumor, called a pleomorphic adenoma, is a benign tumor. And we often see those patients just one time for follow-up, and then give them our phone number to call us if they have any further issues or things they want to discuss. For more significant tumors, malignancies in particular, we usually will follow those patients for several years fairly routinely. Oftentimes we will see them back after they've healed from their operation and get some baseline x-rays, usually an MRI, and then see them once, twice, sometimes 4 times a year, every year for many, many years afterwards. The most important thing is that patients pay attention to what's happening with themselves. Mm-hmm. That's probably more important than any exam we do or any x-rays we do. So we always caution patients you should feel what your surgical site feels like so that you can do a self-exam and do that routinely. And if you feel a lump, you shouldn't wait till your appointment in 4 months to see us. You should call us and come back mm-hmm. and see us. We'll see you right away. If patients have pain, that's usually concerning to us, and we want to hear about that pain and make sure that that pain is expected, and if it's expected, treat it, and if it's not expected, to evaluate it. And there will be other symptoms, facial weakness or twitching in the face. Sometimes patients will have feeling of creepy crawlies under the skin. Those are all things we want to hear about. So we want to have open lines of communication with our patients so that they feel like they're part of their recovery and part of their surveillance program, because they're probably the best advocate.
Perfect. You guys have offered up some very valuable information today, so thank you. We have reached the end of our time today. Thank you for joining us. Again, please leave questions below in the comments section. We will continue to monitor and answer questions after the broadcast. Thank you so much and have a great day.